Welcome back, everyone, to episode 34. We are discussing patellar tendinopathy. I am Dr. Janae Brown, and I am joined by my three favorite physical therapists. To my left is
Dr. Bay.
And to my right,
Dr. Daisuke or Dr. D.
And I'm with Dr. Sandoval.
and we're going to talk today about patellar tendinopathy. I actually wrote this blog this month, and so I'm pretty excited about it. I wrote it because, well, basically Dr. Bay took ACL rehab, which, I wanted, but I gave it to her. I'm just kidding.
She gave you the choice.
No, I'm just kidding.
And
We fought a box for it, and she beat me. So basically,
I was pushing my knowledge.
That's right.
For my current clients.
You were, yeah, and it was a wonderful blog and discussion. So it was a good choice. I have treated a lot of patellar tendinopathy in my day, and it has evolved. The research has evolved based on our evidence and my experience. We are changing the way we treat it. We've called it a lot of different things. It's been called patellar tendinitis. It's now called patellar tendon issues, and patellar tendinopathy is what we know it for. People know it for jumper's knee. So we call it a lot of different things, and it's addressed a little differently depending on some of that. But in general, patellar tendinopathy is an issue we see very common in sports physical therapy, and so I'm excited for us to dive into this. So we're going to cover anatomy. We're going to cover how one would get patellar tendinopathy, so how you would injure your patellar tendon, and we are going to talk about treatment options and kind of what rehab looks like. So I'm going to stop fumbling over my words and pass it to Dr. Bay, and she is going to bring it in for the kill and talk to us about anatomy.
Yes.
And how you injure your patellar tendon.
Yes. All right, here we go. I'm going to redeem myself today. This is our knee.
This is our knee on drugs. Any questions?
This is our right knee.
Nice.
This is the fibula. This is the tibia.
Say it with confidence.
I'm still a little worried I'm going to mess up. I'm under pressure. Okay, here we go. So I want to teach you exactly where your patellar tendon lies in your body. So to orient ourselves, as I just said, we have our tibia, we have our patella, also known as the kneecap, our femur bone, the big thigh bone. So the patellar tendon runs from the base or the inferior pole of the patella to the tibial tuberosity. It is a fibrous connective tissue, and its primary function is to translate forces of the knee. When the quad is firing, pulling up on the patella, it translates the forces so that we can extend our knee, and also to stabilize the patella during various knee movements of different directions. The common way to injure our patellar tendon is through repetitive stress and overuse. So when we have a big increase of training volume, and you'll see this primarily in sports like basketball, volleyball, track, there's going to be degenerative damage to the tendon. These microtears that happen are going to result in pain, weakening, maybe swelling or heat to our tendon. So if we are seeing an athlete increase their training volume, or they're deepening into their season for their sport, they're doing a lot of extra running, jumping, changes of direction, and these stresses might cause that overuse to the tendon. So secondarily, you might also see people get this just because their body has imbalances. They're using some areas too much and other areas too little. Just general muscle weakness. I think in a lot of our young athletes, we see this when they become weak because of a growth spurt, maybe, right? Some of their tendons get extra stressed because there's that moment where they're just weak, trying to catch up to the growth, errors in training, and then also some people are just genetically predisposed to this condition.
Correct. Yeah. Good stuff. We used to think that patellar tendinopathy was due to inflammation of the tendon. And we used to tell people that a lot, that your tendon is inflamed. Now your tendon can get inflamed, but what we really see the issue is in the microtears in the tendon. Now that's the big kind of talking point, is that there's sort of these little tiny tears in your tendon. And so we used to address it a lot with like things to reduce inflammation, and now we address it more in trying to heal like the tendon essentially, right? In our rehab, our approach to our rehab. Some people still address the inflammation, and so we haven't got there yet, but this is kind of where we're at with research. So, and then if we have a really bad, case of patellar tendinopathy or repeat patellar tendinopathy, right? You're at risk for tearing your patellar tendon altogether, or rupture, right? And have you guys had a rupture at all?
Mine was more of a traumatic incident, so it
Okay.
wasn't from repetitive
Stress.
or anything like that.
Have you had a rupture before?
No, but I definitely have had people with just blunt trauma
Okay.
with tendon injury
Okay.
to the patellar tendon.
I haven't had anybody, I don't know if I've had anybody from like repetitive stress, overuse, and then they tore their tendon, but I feel like I've had one patient, I just can't recall it off the top of my head, but it does happen.
The
So,
only ones that I know, I think that happens as far as, from social media and stuff that I
Yeah.
see is weightlifters, powerlifters. I think I've seen like a bilateral patellar tendon rupture.
yeah, I actually
Yeah.
saw one in person at a strongman
Wow.
competition. Yeah, that was
Owie.
not fun. Yeah,
Fascinating
yeah,
in a weird way.
yeah, exactly. No one wants to do that. No one ever wants to do that.
No.
All right, so we've talked about anatomy and mechanism of injury. We're going to go into treatment options. What are some things that we actually do to address this condition? And so Dr. Daisuke, is going to guide us through that. So Dr. D, talk to us. What do we do?
So, I mean, at the beginning, right, if you have a lot of symptoms and stuff, you might utilize icing, elevation type of stuff, or more of symptom modification more than anything, or modulation than anything else. And then we want to start rehab right away. So we're going to modify our activities as well. So say it's due to a running injury, this person can't currently run, but we can still do some type of strength training or walking or whatever it may be at that point that they can do. We're going to start that right away so that we're not losing the capacity too drastically right off the bat. So it's going to be two things we start off with. Taping is one of the interventions we also use too, for same concepts, symptom modulation, manual therapy, same concepts, trying to utilize our sensory system, our neurological system to calm things down, make things feel better so that we can move better, so we can continue and build off of our rehab as well. Strength is going to be obviously a big part in combination. We use blood flow restriction training or technique in our clinic. I think it's a great way to load the tendon lightly but still promote more growth hormones so that we can promote more of that healing aspect and start off with our strength training as early as possible. Muscle flexibility, joint mobility, obviously if they have any limitations there from probably prior to the injury itself too, we can address that right off the bat. And changing movement mechanics, I think Dr. Bay went over it a little bit too with some, when it comes to teenage athletes that haven't really gone through too many movement technique type of training, whether if it's from a physical therapist, personal trainer, or their coach, that can play a very large part in loading the tendon too much too soon. So that's definitely something that we try to address as much as possible, depending on what type of athlete they are as well.
Awesome. Cool. Okay, so those are our treatment options. I feel like with patellar tendinopathy, we used to spend a lot of time, I feel like we used to circle around in the beginning phase, like in the pain and inflammation phases. I think we're getting better at getting out of those phases because we're utilizing strength training so much more and tendon loading more. We've seen a lot better results from approaching it that way. But I think we used to spend a lot of time there, so I think it was addressed like almost like a lateral epicondylitis sometimes, where it's like you keep irritating it. We couldn't manage the load, and so patients kept irritating it. We spent a lot of time in those like kinesio taping, soft tissue work. Ultrasound was used quite heavily before with.
Still used.
Yeah, it's still used. Yeah, but just and I think we're getting better at it. So we're not using some of those pain and inflammation strategies like we used to, but yeah. So okay, let's talk about the beginning phase of rehab. Dr. Sandoval is going to take us through that.
Yeah, so first and foremost, not every athlete when they come to us, they're not necessarily going to be in that beginning phase of rehab. Some of them may be coming in a little bit farther into their journey when it comes to this diagnosis, but assuming that you are just freshly into this condition, right? Typically this would last anywhere between 1 to 4 weeks. It takes about a month to kind of address this issue initially once it starts. Initially, what we do want to do is, still tackle that pain and swelling that's there initially, but like you said, not focus too much in on it, right?
Yeah.
Like you said, we want to, get the quads active, get the surrounding musculature engaged a little bit more, and gradually over time improve the mobility and capacity of that tendon and of that whole knee joint, right? And then going back to what Dr. D and Dr. Bay said, addressing any asymmetries that are already present that you can tackle without causing pain. Those are things that we want to do initially. So some options do include some soft tissue work, right? But then, kind of like what you're saying, yeah, we do want to tackle this more with strength training initially. If they are a little bit more irritable, we can start with some isometrics, doing something within a painless range of motion and holding that muscle tension for a longer period of time can be, it can feel good to the person, right? And then it'll actually help them feel a little bit more confident with their own abilities too. So you're not just working on the actual structure behind the knee, but you're also working on them and their own self-belief of like how they function as a person. Then gradually want to expose them to eccentrics and then isotonic work after that.
Awesome. Cool. And how long does typically the beginning phase last?
Yeah, it can take anywhere between like 1 to 4 weeks, about a month.
Okay, perfect. What are some things that some exercises you guys use in your beginning phase of rehab? Like personally, I know we're all different. I mean, you utilize different techniques. So what are some things you guys would typically touch upon if you had a patient that came in and it was like a fresh patellar tendinopathy that has a moderate amount of pain, some localized swelling, and irritability with extending their knee, resisted knee extension and forces? What would you guys do? Thoughts? Anybody?
Well, right now, our male doctors have been learning from me that it's fun to use the Pilates reformer to reduce load but still move pretty big.
That thing is so much fun.
I know. We've been having a good time with the learning. So that's something I like to do in the beginning phases of the treatment if it's tolerated, is keep people loading but less than gravity, less than body weight.
Yep. Anybody else?
I mean, that's what I've been using recently, so.
You're like, oh, that's what I've been doing.
Yeah, but if they can do some isometrics, like Sam was saying,
Yeah.
I can definitely start off with
Definitely
those
our
different
BFR,
positions.
right?
Yeah,
Like you
I was gonna
said.
say, I was waiting for you to say BFR.
Yeah.
But I mean, you talked about BFR early on, but Dr. D utilizes BFR heavily. So does Dr. Bay. She likes to use rock flosses, doing some of the BFR stuff, utilizing that as well. I tend to be all over my patients with isometrics at home, and tapping into that. Like if they overload at home, if you give them some things to do or they're in their functional activities, I just say go back to those isometrics. Go back to that as you're pain reducing, calming down your tendon. But that's home. In here it is. I think we focus on hip work, right? We were doing a lot of teaching them, hip single leg work, hamstrings, going after things that feel good. So just because they have pain, right, in their patellar tendon with knee extension, what can they do pain free, right? And then I think this is a huge period of literally education on what they're doing at home and activity modification and stuff. So just really spending time to say, okay, you're hurting. What did you do from the last time I saw you? And did you overdo it? What do we need to do to keep your pain levels between 0 and 3 and not really too much over that, for the things that we give you. So, yeah. Any other thoughts on beginning phase?
Yeah, I think just reiterating that to the person, to the patient, making sure that they're still moving and doing what they can, right, is important, because a lot of people will want to just rest, and to them resting means not being active anymore.
Yeah.
And we don't want to do that. We
Yeah.
want them to be as active as possible within the capacity that they have right now.
Yeah. What are some things you guys think are aggravating typically when people come to us with patellar tendinopathy and they're coming in that beginning phase? What are the things that are typically aggravating for them? and then what are the things that actually feel good. So if we were to generalize, like what are some exercises we would typically say, okay, these are some things that you're probably going to be fine doing and your knee's not going to hurt. Any thoughts?
You're smiling. What would you like to
Would you let
say?
them do like ham curls? Like, are those going to bother them? The ham curl machine typically?
Probably not.
Yeah.
That's probably going to feel good.
Yep.
So that's something that we would want to do.
Yeah. Cool. What about squats below, 90? You're going to say get low?
I think again, as long as they're feeling okay, then yeah, sure.
Yeah.
Right?
Well,
but
typically
it really
squats
depends.
bother them though, but like if they
Yeah.
get low and do a low squat, this is where it's irritable, right? Because of the way so
Yeah. So at that
High
point, you might
heels.
want to.
high heels.
High heels plus drop it low. No.
Yeah. So at that point, you might want to modify the way that they're actually squatting, right, to reduce the load on the knee and maybe drive it more to like a hip strategy
Mhm.
for the time being. So like you had mentioned, and Dr. D had mentioned early on, like addressing movement mechanics, and I think Dr. Bacon said this too. Movement mechanics are, just the way that the person's moving, maybe adjusting that early on and changing some things, giving them different strategies to move into those positions that they want to get into.
Yeah.
As long as it's painless or pain-free, then you should be okay, and then gradually progressing them back to where they need to be for whatever activity they're trying to get back to.
Will stairs feel good? Like coming downstairs?
Typically, no.
No?
Usually going up will probably feel better than going
Coming
down.
up feels better.
Yeah.
What
Sitting
about
for
running?
a long time.
Sitting for a long time is bothersome. Yep.
Keeping your knee bent for hours.
Yep.
Yeah,
These are
like
some things
that.
you guys got to look out for that might cue you into like might be this problem. But there are again a lot of things we can give you, especially if you're training and you're going to the gym consistently. There's a lot of things you can still do. So it's not an all or nothing. I think that's a big takeaway in the beginning phase to teach our patients. There are things you can still do.
Yeah. Especially a lot of the current research with tendon-related injuries too is that I think they were saying that exercises that cause zero pain did not necessarily promote faster healing than exercises that cause a little bit of pain.
Yeah, for sure.
So
Yeah.
as long as it's like you were saying under like around like 3-4-ish or
Yeah.
under that, I think it should still be fine. So just like you were saying, reiterating to them that just because you have a little bit of pain with certain exercise doesn't necessarily mean you have to take it out completely.
Yeah.
As long as you can recover from
Yeah.
it in a short period of time.
I think that's a big thing with this too is just everybody's like idea of what pain is. Like if you say, I want you to do this to tolerance, right? Like tolerance for one person could be like 6 or 7 and then they wake up the next morning and they can't do anything. So it's really like working with each person individually and saying, okay, well we don't want you when you wake up in the morning to like your whole day to be shot. So we need to pull back maybe your tolerance, so that's why this is an individualized thing where you work one-on-one with people because some people can handle things that others can't, and it's really about function, and what they can do the next day. Okay, I'm going to cover middle phase and late phase of rehab, which is the fun stuff typically for us. The middle phase of rehab is going to be typically 4 to 8 weeks of time, and in this time frame, the goals that we have are progressive strengthening. So we're really trying to increase the load on the knee, build tendon resilience and resistance during this time. We want to work on improving balance and control, and just higher levels of just being able to tolerate stability. We want to address muscle imbalances in the whole lower chain and the whole body really, but addressing any muscle balances we see. So if the hip flexors are tight and the glutes are weak or opposite, sometimes we have different things going on in the lower extremity. We're going to address those things more specifically in this phase. We are going to look at movement mechanics. How is this person moving? How do they squat? How do they run? How do they sidestep? How do they go up and down stairs? How do they get up, up and down from the floor? How are they moving in general? And then we are going to initiate some dynamic movements during the middle phase of rehab, including some plyometric movements, so some jumping movements. Typically we do a lot of smaller stuff in this phase. It gets to build to bigger stuff, but smaller stuff. And then really this is the phase where we're probably getting our patients in this 4 to 8 weeks back to the gym. And so we're trying to teach them how to manage load. You know, how much can you handle? Sometimes it's like these things feel good. You can squat, you can lunge, you can step up, you can deadlift, you can do things, but maybe you can only do one thing a day, or maybe your training has to change a little bit, and how you're, you know, putting your training together. Maybe you're not able to do 10 exercises, you can do 5, or maybe you can do 5, but you can do 3 sets of 5 versus 3 sets of 15. You know, we're gonna just like work with our patients to make sure that they're feeling good day to day based on kind of what we just said earlier. So, treatment wise, so those are goals. Treatment wise, we're working on, you know, specifically isotonics. So now we're moving sort of away from isometrics and trying to do things against resistance, both concentrically and eccentrically. We're working on heavy, slow resistance training in this phase typically. We are going to be doing squats and lunges and step ups and all those things. Working on neuromuscular control. Yeah, so what are some things you guys like to do? I just mentioned a bunch of stuff that we can do. So what are some things you guys like to throw in the middle stage? Or Dr. Sandoval, what does Dr. D like to do in this phase? you might know.
Split squats.
And pogos.
Pogos.
That's where I was gonna go to. Yeah.
Pogos. And he
Split
does
exchange,
an exercise where the foot
forward
goes
and
on the
lateral
wall.
progressing.
Foot goes on the wall, one leg is in the air. Something's happening. Some pressure through the foot
That one's different.
glute.
The wall
What is
stride.
Oh.
The wall stride. Oh yeah.
That's his hamstring
James
prep.
Erdemans loves that one. The wall
Hamstring
stride.
oblique prep.
Yeah.
This
He's
was
like,
good.
that's my
That's
go-to.
so great.
What about open kinetic chain stuff? Knee extension on. Are we working that in this phase?
Yep.
Yeah, for
Okay.
sure.
Close always, as early as possible.
Perfect. And let's see. What does Dr. Sandoval like to do in the middle phases of rehab? You know, Dr. D?
Do you even have anyone with patella?
I have one person, but it's driven by something else.
I bet he works on muscle imbalances via the Captain Morgan
Mm.
Oh.
or a split squat with an adductor. ISO with the foam roll.
Yes.
Dr. Bay
Yes.
knows.
I pay
I'll
attention.
try.
You guys are good. Look at this collaboration
I
and
know what they do.
observation we have in place in this clinic. Oh my gosh. Okay, so let's go into the late phase of. Do you guys want to add anything else?
That would be fun.
Okay, cool. Late phase. So late phase is 8 weeks and beyond. We're just basically going after aggressive strength here. My idea of aggressive strength and Dr. D's idea of aggressive strength are a little different. He will make your butt work, okay? So you're doing some really heavy Bulgarian split squats with Dr. D when you're getting probably into these phases. We're doing...
Oh, and he'll make you do like 5 sets.
That should be.
Yeah. We're working on performance in this phase, so we're working on return to sport stuff. We are doing a little bit of that in the middle phase and initiating some return to sport stuff, but in the late phase, we're really going after sport-specific drills. We're working on agility and coordination, so sport-specific drills, cutting, pivoting, jumps, you know, lateral and linear acceleration. We're doing agility and coordination, which is ladder drills and cone drills and shuttle drills. We are working on power in this area, power and plyometrics. So we're doing box jumps and jump squats and lots of hops and things like that.
Would
and
you slam the ball in this phase?
I might slam the ball in the middle phase,
Yeah.
depending on maybe like standing ball versus like half tall kneeling ball in the middle phase, depending on how they felt on their knees. Although again, we're trying to get them to feel good in those positions, so it just depends on the person. But yeah, I will slam the ball in any phase actually.
Great.
I might slam the ball in the
It's a
beginning
good
phase.
power.
Strength and endurance training. So we're working back to if someone's a runner, this is where we're just working on their running. We might adding some sprinting in here, and then we're continuing with maintenance. So you know, stretching and all the things that we're doing to feel good, mobility work, any things like that that are just keeping up with feeling good, and then functional training. So you know, how are they moving? How are they moving their sports? And making sure we're really just getting them feeling 100% back to whatever it is that we're doing. So that is the late phase. What do you guys like doing in the late phase? What's your favorite thing to do in late phase?
Sprinting.
Sprinting. Oh yeah, Doctor.
Linear acceleration and sprinting for sure.
Yeah, I see you practicing that yourself, so you enjoy that. Anybody else like something in this phase or like training the specific thing in the late phase of rehab here?
I just like to come up with jumps that mimic, like for my dancers, like that they're gonna have to do in the routines. Like if they're taking off forwards or sideways, if they're landing backwards, or exposing the same forces.
Dr. Sandoval, anything that you enjoy doing in this phase?
Things that I enjoy are working on jumps too.
Yeah.
Just different types of jumps. And hops, leaps, those types of
Bounce.
progressions. Bounce.
I really enjoy I like the acceleration stuff too, but I like the transitions. I love the pivots and the having to come from the ground, to run or to
Level
the
change.
the changes. Yeah, I'm really seeing people be challenged by some of that.
What about deceleration work as well? Right? The change of direction.
Oh, I love decel work too, starts and stops. Yeah, so yeah. Okay, well that is what we do when we treat patellar tendinopathy. And so I think the biggest takeaway for us with patellar tendinopathy, it is a tendon issue, so it's a load management issue. So I think in every phase, what we're really paying attention to is as we add more load, how does sort of the tendon respond, and does it continue to heal, and can we continue to progress? And the thing that stops us is when our patients do things that we feel are going to limit them. For example, I've had a basketball player patient, Dr. Bay and I think treated a little bit together, where he would just play and I'd be like, you are not ready, or he'd play multiple games and he wasn't ready, and then he just kept going this cycle where we were just always dealing with pain. And so if you do not manage what you do, and what you do exacerbate your pain, then we are going to be just on a huge
Circle.
hamster wheel, right?
Right.
With this, yeah. So that's the biggest thing. So that's your takeaway from us: is work with someone who is a great PT who knows how to help you manage your load. If you are looking for a great PT, we are here. We treat patients virtually and in person here in San Pedro, California. So look us up, find us on Instagram, Facebook, YouTube. Our YouTube stuff is up. So our YouTube, these discussions are on YouTube. You can watch the whole thing, and you can also find us in the next month on our podcast, which is gonna be up and running for you guys to follow us. We are also newly on Threads.
Yes.
Have you guys you're on Threads?
I'm on
I saw.
Threads.
Yeah, Threads. Dr. D
I don't
is.
even know what that is.
We're gonna get you guys going. But
What's
Threads is a
Threads?
brand new Instagram. It's like Instagram's Twitter.
Oh no.
So it is up and running, and we're on there as well. So
I'm too committed to the gram.
I know
It's
it's
part
hard.
of
It is the
It's
gram.
connected.
It is the gram. That's what you need
That's
to know.
the new gram.
And what else? I think that's it. We'll see you guys next time as we enter into ankle injuries. And so stay tuned.
Oh, it's
It's happening. Bye, you guys.